Thank you for having me this morning, and good morning. My pleasure to present the result of the randomized phase 2 study of CABOzantinib versus SUNitinib in untreated metastatic RCC patient of poor and intermediate risk. So as a way of introduction, CABOzantinib, the experimental drug in question here, is an oral inhibitor of tyrosine kinases, including not just the VEGF receptors, but also MET and XL. This drug was approved in the United States and in the EU for previously treated RCC. So our question here was to evaluate CABOzantinib compared to SUNitinib in treatment-naive RCC patient of poor and intermediate risk group. We felt that poor and intermediate risk group are an unmet need and usually have inferior clinical outcome relative to favorable risk patients. The primary endpoint in this CABOSUN trial was progression-free survival as assessed by the investigators, with secondary endpoint being overall survival as well as overall response rate and safety. Just to put this study into perspective, especially that it deals with intermediate and poor risk patients, which usually together represent the majority of RCC patients. So CABOSUN, the trial in question here, compared to two more so contemporary trials. So CABOSUN did not enroll any favorable risk patient. Record 3, which is a study frontline of SUNitinib versus everolimus, and COMPARES, which also a contemporary study published in 2013 of SUNitinib versus CABOzantinib. Both enrolled 25 to 30% favorable risk. CABOSUN enrolled 13% of ECOG performance 2 and 36%, the highest among the three trials of patients with bone metastases. So that to show you that this study really had many patients with negative adverse prognostic factors, even beyond these poor risk criteria, ECOG performance status 2 and prevalence of bone metastasis, more than 1/3 of patients. So no patient with favorable prognosis, higher rate of ECOG performance 2, and higher rate of bone metastases, all associated with poor prognosis and poor response in the metastatic setting to VEGF targeted therapy. Overall, these are the result. Treatment with CABOzantinib resulted in a median progression-free survival of 8.2 months compared to 5.6 months with the control arm of SUNitinib. This was statistically significant. The hazard ratio was 0.69, corresponding to a one-sided p-value of 0.012. What about overall response rate assessed by investigators? In the CABOSUN trial, overall response rate from CABOzantinib was 46% by RECIST compared to 18% for SUNitinib. As you can see, the confidence interval do not cross, suggesting statistical significance. Overall survival is very preliminary. The median follow-up is short, the numbers are the following. Median OS with CABOzantinib 30.3 months, 21.8 versus SUNitinib. Hazard ratio is 0.8. We intend to have in the next several months an update for the overall survival. In terms of safety, the median number of cycles, each cycle was defined on the study as 6 weeks. Usually we followed SUNitinib here because that's the cycle for SUNitinib. It's given 4 week on, 2 week off. So with CABOzantinib, the median number of cycles is 5, with SUNitinib 2. Grade 3-4 events were not different. Dose reduction was slightly higher with CABOzantinib. However, discontinuation due to adverse event was 20% in both arms. There was no surprises in terms of side effects. These are side effects that do represent a class of agents, VEGF target therapy, hypertension, Diarrhea, PPE, and fatigue are common side effects with both drugs. There was a greater exposure in cabozantinib arm and similar rate of adverse event and discontinuation between both arms. So, what are the implications for the treatment of metastatic renal cell carcinoma after this study? We'll go back and say that SUNitinib is a standard of care and the most used agent in first-line metastatic RCC. Median PFS 8 to 11 months in a general unselected population of good, intermediate, and poor risk. Patients with intermediate and poor risk, these 70% on average, have worse prognosis. There is data from the International Metastatic Database Consortium that showed that these patients, when you treat them with first-line targeted therapy, their PFS could be as short as 5.6 months, which is exactly what we found in the control arm. So in cabozantinib did improve progression-free survival and overall response compared to SUNitinib, 8.2 versus 5.6 months, overall response rate 46% versus 18%. There was a similar safety profile. I do believe that cabozantinib represents a potential first-line treatment option in patients with advanced renal cell carcinoma. Thank you.
Thank you.